first topic, and I get asked this a lot in the office, is the usage of carbidopa, levodopa, and whether to introduce this drug early or late in the course of Parkinson's disease. Now, historically, carbidopa, levodopa, most of us believe has always been the most effective option for treatment for Parkinson's disease since it came out. Um, in my experience, carbidopa levodopa does have overall, for patients typically above the age of 70, it has the lowest side effect profile. And so if I have a patient with a new diagnosis of Parkinson's, let's say they're age 75 or so, I will oftentimes go straight to carbidopa levodopa without using any of the other the alternate medications. Now, patients always ask me what is the downside of using carbidopa levodopa, and the consensus thought among many Parkinson's specialists is that one, when you have dosages of above 400 milligrams of the levodopa, so for example, your traditional tablet is the round yellow tablet, 25/100. Each tablet has 100 milligrams of levodopa. So if you're taking 4 tablets or more a day, there's a risk that you can get dyskinesias with long-term usage of carbidopa levodopa. The dyskinesias, for those who aren't aware, are the involuntary movements. If you've seen a clip of Michael J. Fox recently, he's constantly moving around. Those are called dyskinesias. Patients also get the off and on fluctuations and can get hallucinations with the drug. Now, personally, I believe if I have a younger patient, maybe 55, 60 years of onset, I'll use some of the other agents first and then try to hold off on using carbidopa levodopa, just because I don't want to induce dyskinesia so early on in them.
Yeah. Back in the day, and I'm a little older than Dr. Shah here, so my age might come out with what I'm going to say. But back when I was a fellow, and this was more than 25 years ago, there was a study called the ELLDOPA study. And the purpose of that study was to determine whether levodopa was toxic or not. Because if you read the literature, if you go through the internet or comb what the literature online, there will be some forums that will say, well, maybe we should not use levodopa in the beginning because if you do, they observe that those that take whopping doses of levodopa in the earlier stages may develop dyskinesias. These are the squirmy movements like this. The average onset is about 5 years or more after starting levodopa, and then they also develop what's called motor fluctuation. So from 3 times a day, then it becomes 4 times a day, then 5 times a day. So the effect of the medicine becomes shorter and shorter. That's called motor fluctuations. Whereas in the beginning, you have what's called the long duration response. What that means is you can forget your medicine, be late in taking your medicine, and nothing happens because you're still in the early stages. You have a buffer, so to speak. You sort of store the levodopa or the dopamine in your brain, and then you kind of use it on demand, and you lose that buffer after an average about 5 years. And the question is, will levodopa accelerate the onset of dyskinesias and the so-called motor fluctuation? So what they did in the ELLDOPA study, they compared patients that started that were delayed in use of levodopa being given placebo versus 150 milligrams versus 300 versus 600. And what they found was those that took the higher doses of levodopa down the road had earlier onset of dyskinesias and motor fluctuations, although they did better though. So motor-wise, their symptoms were a lot better. And then they did DAT scans on these patients, and they found that those that were exposed to levodopa early had acceleration of their DAT scan findings. So DAT scan is, how many of you are familiar with the DAT scan? It's like a dopamine scan. It's like a Parkinson scan. So it is a scan that helps determine whether your dopamine levels are really low or not. That's called a DAT scan. So having said that, I think, I'm not sure, in your in your generation, and he's a little younger than I am, as I said, but in your generation,
But he looks younger than me though. He doesn't even have any gray hairs.
well, that's called tinting here, right? But I was going to ask, but in your generation, because in my generation, because of this L-DOPA study, we were we were encouraged to use levodopa sparing strategies because of this L-DOPA study. Levodopa sparing means use something else weaker, like selegiline was a big thing back then. There was pramipexole, there was ropinirole, there was bromocriptine. There was pergolide, which is another dopamine agonist. But in your generation, were you encouraged to do levodopa sparing drugs first, or just from the get go, let's do levodopa. Life is too short. Make patients happy.
So typically, if the patient is above the age of 70 at onset of Parkinson's, I'll typically go to carbidopa levodopa directly. The reason for that is some of the other agents like ropinirole, pramipexole, amantadine, they actually have higher side effect profiles in the elderly population than carb levo does. But if I have a younger patient who can tolerate those side effects of the other drugs better, I will definitely utilize levodopa sparing strategies.
Yeah, and thank you for mentioning young, because the younger you are, the higher the chances that you will develop dyskinesias and or motor fluctuations early. And so it is of much more interest, at least in my books, to start younger onset Parkinson's, with the so-called levodopa sparing strategies, and see, how far they can go, how long they can go without levodopa before starting levodopa. And so the question is, how young is young? What is, I mean, you mentioned 70, but can it be younger than 70 though?
Yeah, I mean, usually I use 70 as a cutoff point. So if I have, let's say, like a 67-year-old with a new diagnosis of Parkinson's, I will actually use the sparing strategies first.
Agree.
So I'll start them on ropinirole or pramipexole or amantadine first, and then see how they do, and then later on transition them to
Yeah.
carbidopa levodopa.
Now, here's a theoretical situation, which actually I see in clinical practice. But what if this is a young onset Parkinson's, 40-ish, 50-ish, maybe? You've tried the levodopa sparing strategies. They're not working. Patient is disabled. Patient is a doctor, I don't know, a lawyer, very productive, a movement specialist, maybe, who knows? But if the levodopa sparing strategies are not enough, would you hesitate, despite their young age, to put them on levodopa?
No, because then I'll just take them to brain surgery in a couple of years. But we'll get to that topic.
Of course, of course.
No, so if I've tried the sparing strategies first, and let's say they just can't tolerate the alternative medications, I will explain to them the risk of starting carb levo early, but then at the same time, since everything else has not worked, that's probably the only resort they have to get improvement.
Yeah, and the nice thing about using the levodopa sparing strategies in the beginning and then add on levodopa is that you're able to keep the doses of levodopa controlled and lower. In fact, I like it that you posted this 400 milligrams, and the basis for that is a study which came out after the L-DOPA study, I'd say about 10 years after, called the STRIDE PD study. And whereas in the L-DOPA study, it was the 600 milligram dose or higher that were associated with faster acceleration of the disease. In other words, the higher the dose, we kind of say, oh, maybe high doses, 600 milligrams and above. 10 years after, the STRIDE PD study showed that anyone taking more than 400 was more prone to developing earlier dyskinesias. And so I kind of like that Dr. Shah put here the 400 milligrams, because it's a rough guide, although it's I don't think that all of us subscribe to that, but I think, but I actually do. I
It's
actually
not
do.
a concrete line, but I think it's a suggestion.
It's a suggestion. It's a controversial issue among movement specialists, but I concur with you. I also, if I use the levodopa sparing strategies in the beginning, and then I'm forced to add levodopa at some point because patient is still disabled, patient is still not good, patient is not able to write, patient is not able to walk, perform his job, then I will add levodopa, right? And because there was already selegiline there, or there was already rasagiline or pramipexole or the so-called levodopa sparing strategies, now I'm able to keep the dose of levodopa below 400, and patient will be able to function, the longest time. on these medicines.
What's your opinion on, there is some thought about Rytary, and some Parkinson's specialists believe that if you initiate with Rytary first, actually Rytary does not, the 400 milligram line of Rytary is actually higher. So Rytary does not initiate dyskinesias as early as carbidopa.
Yeah.
Do you believe in that? Have
Well,
you seen evidence of that
well,
in practice?
first of all, let me ask the audience. Do you know what Rytary is? Have you heard of Rytary? If not, then you better go there at the table afterwards, right?
No, that's right. The Rytary rep is
Rytary
here.
rep is right there.
Yeah. So Rytary, for those that don't know,
Okay,
is
please.
a brand name version of carbidopa levodopa that is a capsulated form, and it contains both the immediate release generic carb levo in there, as well as the extended release.
Right.
Rytary has a different release pattern, and tends to last a little bit longer in the blood than traditional carbidopa levodopa does. But years ago, one of my mentors, Dr. Mogel at Barrow,
I love Dr. Mogel.
he told me that there was a study done that showed that Rytary did not have the same dyskinesia risk as generic carbidopa levodopa.
Okay, and again, first of all, I don't think there's really clear studies that have said that starting Rytary from the onset will delay dyskinesias and motor fluctuations. Let's first state that.
Right.
There's no studies that say so. Number two, that strategy has been done in the past. They actually compared Cinemet CR in the beginning versus regular Cinemet. Carbidopa, levodopa, and the question is, if you introduce long-acting levodopa in the beginning, as against the short-acting, and what's the difference between long-acting and short-acting in terms of development of dyskinesias and motor fluctuations? Because they think the reason why patients develop, this motor fluctuations, dyskinesias, is because it's pulsatile way in which you take a medicines that's short acting, it rises in your blood, that's the peak, right? And then it peters out after 4 or 5, maybe 6 hours. Then you take another dose, then you pulse it again, it peaks, and then it peters out after a few hours. Then you pulse it again. So this is called pulsatile stimulation of the dopamine receptors. They thought that if you introduce the levodopa CR or controlled release, there is no pulsatility, that it is more evened out. Although the truth of the matter is, although it evens it out, maybe the peak is not as high. The truth of the matter is there is still some pulsatility. It's just less pulsatile than the immediate release. And so my take on this is that whether it be Cinemet IR, which is carbidopa levodopa immediate release, plus the Cinemet CR together, which is a cheaper, alternative because they're both generic, versus Rytary, which combines both all in one. I think you will not be able to get around the pulsatility. Now, why is it that patients perceive that that Rytary seems to have less of dyskinesias? Because the milligram strength is different. It's not 1:1. Like for instance, Rytary comes in different numbers, and I'm going to talk about the bottom number, which is the levodopa. So for instance, it comes in 95 milligrams levodopa, there's 145 milligrams, there's 195 milligrams, and 245 milligrams. And then the question is 95 milligrams of Rytary equivalent to 100 milligrams of the generic levodopa? And the answer is no. And in the beginning, we didn't know how to do this. So in the beginning, Parth and I and Dr. Mogel, when this first came out, we would do it 1:1. And what would patients experience?
It didn't work.
Exactly. They'll say, gosh, this thing doesn't work.
But it's a 2-to-1.
In fact, I even use 3:1 in my practice to get that oomph. The thing that patients with immediate release carbidopa, levodopa miss is that oomph, that peak. It gives them a little bit of a high. So dopamine has a mood elevating effect. It's a feel-good neurotransmitter. So if you remove the peak, and they're so used to this peak, and this happens also after DBS, right? When some of our patients, they're wonderful, they have no more motor fluctuations, no more tremor, no more dyskinesias. You've reduced the medicines dramatically, if not wean them off, and they feel lousy, they feel crappy because they don't get that high that they used to get from dopamine, the peak. And so this is something that we don't see in immediate release or in Rytary. So that's why the way to kind of get that oomph is to increase the dose. And at least in my hands, I think a 3:1 conversion will give them a little bit of that oomph. And then even more so nowadays, instead of me doing a switcheroo, like from immediate release to or generic carbidopa levodopa to Rytary. I just add it on.
Okay.
Because I've lost a few patients in the beginning when I first did this overnight switcheroo because of this lack of a conversion factor for Rytary. And I was going to ask you though, do you start patients on rasagiline, which is a MAOB inhibitor?
I've inherited a lot of Dr. Samantha's patients.
Right, right.
And he was a fan of rasagiline, and a lot of those patients do feel benefits of rasagiline. But the funny thing is, every time I've tried a patient on rasagiline, they say it doesn't work. So I'm not sure. I have mixed feelings on rasagiline. To be honest with you, it is not something I reach for often in my toolbox.
Got it. But is there a certain population that you would probably use it for?
I think a younger patient who has very mild symptoms,
Agree.
I would probably use the rasagiline as a first line.
Agreed.
Yeah.
And the main thing about rasagiline, it's a once-a-day drug, right?
Correct,
There's
once a
very
day.
few once-a-day drugs that you can use as monotherapy. Monotherapy means nothing else but itself. It's one of the only few drugs that's dosed once a day, and you can use it both in the early stages and the later stages. But I agree with Dr. Shah. It's a weak medicine. If you have severe tremor, severe Parkinson, it's not going to do much. But if you have a patient with a very early, mild Parkinson's, possibly one side tremor is not very prominent, I think rasagiline is a decent option.
Now, the extended release dopamine agonists, though, I'm a fan of those.
So what are we talking about? Pramipexole,
Pramipexole
ER,
and
or
ropinirole
XL, or
I
ER?
love
Yeah.
my ropinirole and pramipexole ERs. The problem is a lot of times they're kind of relatively expensive. Insurances won't cover them, but they are also a once-a-day drug that actually is pretty strong. They're not as strong as carb levo, I think, in the long run, but if I had a patient with moderate symptoms, I would definitely try them on the extended release agonist.
Oh, okay. So how do you make a choice now between, let's say, a dopamine agonist like the pramipexole ER or the ropinirole ER versus levodopa? What are your parameters in terms of, I'm going to choose this versus that?
So typically, if I have a patient younger than 70, and 70 has just been my cutoff age, there's no real evidence that, as far as I know, that 70 is like a set in stone kind of line. But if I have like a 65-year-old patient with mild to moderate symptoms, I will jump to the agonist as a first line.
What about tremors? What is your drug of choice if patients have severe tremor predominant Parkinson's? In other words, there's not too much shuffling, there's not too much rigidity. It is tremor that bothers them.
I know this is controversial, but if they can tolerate it, in my opinion, the best tremor drug is Artane,
which is trihexyphenidyl. Yeah. And would you add perhaps maybe a dopamine agonist in that setting if they don't tolerate trihexyphenidyl?
Yeah, if they don't tolerate trihexyphenidyl, and a lot of patients don't, trihexyphenidyl does have a strong side effect profile.
Like what?
Typically, it's always cognitive impairment.
Yeah.
Patients just feel very sluggish and mentally slow on trihexyphenidyl.
And hallucinations. And dryness of eyes.
And dryness of eyes.
Or dryness of mouth.
Right.
Yep.
Yes, if they fail trihexyphenidyl, I would definitely go to a dopamine agonist.
Although, as you said, if patient is elderly, they're probably more prone to these side effects, right?
Much more prone to side effects.
Yeah, but in your elderly patients, would you give a dopamine agonist? And is there a cutoff for that? I mean, I've seen patients that are in their 80s or 90s, I mean, that I inherited and they're on dopamine agonist.
It depends on if they're like a good 78. So if they're really healthy and they don't have a lot of other medical problems, they don't have a lot of memory impairment, yeah, I'll try a dopamine agonist on them.
Now, what does it mean to you if a patient hallucinates on a dopamine agonist? What does that mean to you in terms of, what does this patient most likely have if patient hallucinates a lot with the medicines?
It's been said that patients who are prone to hallucinations typically also have underlying cognitive impairment.
Agree. In fact, I just saw one a couple of weeks ago, and patients swore, put one hand on the Bible, said, my memory is perfect. And yet she was complaining that every time she takes the levodopa, she hallucinates. And I said, wow, that's pretty unusual for somebody, even if you're 75, I don't care. It's not, and you have early Parkinson's, you're not supposed to be hallucinating. So hallucinations and cognitive issues go hand in hand in more advanced Parkinson's patients. If we see hallucinations and cognitive issues or dementia in the first 5 years, we get suspicious for a Parkinson's mimic called dementia with Lewy bodies. So you want to expound on dementia with Lewy bodies a little bit?
Yeah, so dementia with Lewy bodies has the same pathologic molecule as Parkinson's. But dementia with Lewy bodies tends to be a very aggressive disease, and the memory impairment takes a paramount role, where the patient, instead of complaining about their tremors or their shuffling, their main complaint tends to be the memory
Yep.
first. And then they can have some Parkinson features too,
Sure.
some tremors, some walking issues, but the main problem is the memory. The issue is the dementia with Lewy bodies, in my experience, has been a pretty difficult disease to
It is.
treat, and they tend to be very aggressive for us.
Agreed. They're faster, they're less levodopa responsive. And not only that, sometimes the levodopa will worsen the
Will worsen
confusion and
symptoms, correct.
hallucinations and dementia. And sometimes we see these patients in the so-called precursor stage or prodromal stage, or what we call the MCI stage of dementia with Lewy bodies. So you don't get demented overnight. So there's a halfway house. You go from normal, then a little bit impaired, then the halfway house is called MCI stage of dementia with Lewy bodies, or you can say MCI stage of Alzheimer's disease, whatever the dementia syndrome is. There's a halfway house called MCI, which is mild cognitive impairment. And then finally, you cross the line at some point and proceed to dementia. So even when we see patients that are a little bit Parkinsonian and they already are in the MCI stage of dementia with Lewy bodies, how do we suspect that this is early DLB or the precursor to DLB? Because as Dr. Shah mentioned, they will hallucinate. Okay, they have prominent hallucinations and delusions. They're paranoid. They have delusion. They have false beliefs. It's like absurd ideas and beliefs that are out of nowhere. It's like, wow, where did that come from? This guy's supposed to be super smart, right? And yet he's speaking nonsense. So these are delusions. So when you see delusions, hallucinations, and a little bit of fuzzy mindedness and forgetfulness in the beginning, and they have a little bit of Parkinson's. So in other words, cognitive issues almost at the same time as the Parkinsonism. Whereas in Parkinson's disease, when do you develop cognitive issues or hallucinations? How many years on average after?
I usually see it typically 5 to 8 year window.
Agree. It's not an early feature. So if you develop cognitive issues within the first 5 years, couple that with delusions, couple that with hallucinations
Red
and
flag.
paranoia,
Concern
boy,
for
those are
dementia.
red flags. In fact, Dr. Shah is an expert in DBS. And if you see those kind of patients, will you push them towards DBS?
So let's talk about that. Should we?
Why don't we transition to DBS next?
Yeah, so what
That's a good
transition to
segue.
DBS? So two questions with DBS.
Of
Early
course.
versus late, and also would you do it in patients with mild cognitive impairment?
Got it. Okay.
So you know me, I love DBS, and I love,
And I do as well.
and that's right, and I know you do too, and I love the new DBS platforms. I think deep brain stimulation is a game changer for patients. And I use it pretty aggressively in my practice. Now, early versus late. Now, typically the FDA recommends waiting 4 years, I believe.
Correct. 4 years before your insurance will pay for it.
That's true. So, and I think 4 years is okay. I think 4 years gives us an opportunity to try medications, try carbidopa, levodopa, see what the response to the levodopa is, and gauge whether a patient is going to be a good motoric candidate.
Okay, and let me just interject and just add on to that. 4 years is a random number, although I usually use 5 years. Now, why 5 years or 4? Because the so-called Parkinson's mimics or atypical Parkinsonian syndromes, which are not good candidates for DBS, may sometimes respond to levodopa for a few years. It can fool experts like myself and Dr. Shah. And in fact, there was a pathology study that was done here, of all places in Arizona. There was a brain bank program that I participated in. I think you participated in this also when you were at Barrow, where patients would donate their brains and body to science, right? And experts like myself and Dr. Shah and Dr. Mogul would say, yep, you got Parkinson's. I'm going to treat you as Parkinson's disease. And then we asked them to donate their brains and body to science. So they did, right? And so at the end of the project, what they found out was the rate of misdiagnosis of Parkinson's among experts like myself, that we say, yes, clinically, based on the clinical criteria, you have Parkinson's disease, we are wrong 42% of the time for the first 5 years, which is ridiculous, right? That's a whopping number. It was
a large
very humbling. In fact, very humbling. I was one of the first one when this came out. I was one of the first ones to kind of say, "Wow, that's pretty humbling." And so,
And then might I add that number goes up if the diagnosis was made by a general neurologist
exactly.
or a PCP.
And no offense to them.
Yeah, no
right?
offense to them,
No offense
but
to
when
them,
people ask me why do you go see a movement disorder specialist, that plays a role.
because we're already crappy, right? And they can be crappier
Yeah.
than we are. So that's why you have to see
So-
us. So choose between, which is the less of two evils. But having said that, that is the basis for this, that
Correct.
Medicare or their insurance companies do not want they don't want to invest a 100,000 of their funds on a patient that doesn't have Parkinson's disease because it will not work.
Correct.
Okay, so that's the reason.
Correct.
Okay,
The mimics are not responsive to
Correct.
the deep brain stimulation. But typically after 4 or 5 years, if I've gauged that they have a good response to carbidopa levodopa, they start having some complications such as the on-off symptoms, they have dyskinesias. I think those, or if they have tremors which have not responded to medications, I think those are strong DBS candidates.
Agree. So you mentioned a few things. One is tremor predominant Parkinson's. So in your experience, is tremor predominant Parkinson's as easy to fix with medicines, or are they harder to fix with medicines?
So in my experience, tremor dominant Parkinson's are harder to fix with medicines, but they are overall the better prognosis, in my opinion.
Agree. They're more benign, right?
They're more benign.
In other words, the progression seems to be, less, quick.
Correct.
But they're very disabled, right, by their
The
tremor.
tremors, but those tremors will go away after deep brain stimulation.
Absolutely. So these are the patients that will earn a ticket before the 4-year mark. Now, what about patients intolerant of medicines? Have you pushed patients not tolerating levodopa towards DBS, early DBS, meaning less than 4 years?
Correct. I had one patient who I've tried everything on. He was a new diagnosis within the first 3 years, and he just could not tolerate carbidopa levodopa in any of its formulations. I tried the immediate release. I tried the oral disintegrating. I've tried extended release. I tried Rytary. I tried Divi, and he just could not tolerate it for various different side effects. And so I did make the exception, and I pushed him towards DBS early.
Now, one of the predictors for a good response to DBS is a good response to levodopa.
Correct.
Right? In fact, we do what's called an on-off levodopa test before DBS. We measure your Parkinson score. We give you a Parkinson score in the office, and then we give you levodopa. Then an hour or two after, we measure the score again, and we should see at least a 30% improvement of the so-called Parkinson score to say, "Yep, you are levodopa responsive. You're good to go," and the surgeon will be happy to do this. So in those cases where you don't have the benefit of establishing levodopa responsiveness because even a whiff of levodopa makes them nauseous or dizzy or sleepy. So how do we tease out such patients though?
Fortunately, it happens very few times where you don't have to always worry about that. He was an exceptional case. The one thing about him was he was very tremor dominant.
Got it.
And I had confirmed the disease with a DAT scan and the SIN1 biopsy.
Thank you. I guess I was gonna.
So I knew it was Parkinson's, and so I felt comfortable in taking him to DBS.
Okay, so tell us a little about, you mentioned already the dopamine scan or DAT scan. Tell us a little about the SIN1 skin test for Parkinson.
So the SIN1 skin test basically is we take a couple samples of the skin and we send it to the lab, and it looks for the presence of the alpha-synuclein toxin, which is the protein that's in Parkinson's disease. A positive SIN1 test can only occur if you have Parkinson's, MSA, or the dementia with Lewy bodies. Because all of those all of those diseases are SIN1 dependent. So Alzheimer's would show up negative on a SIN1 scan, a SIN1 test. Fortunately for him, when you see aggressive tremors, there's no memory issues. You can effectively eliminate dementia with Lewy bodies and Shy-Drager as possible diseases.
Yeah. Although I'd have to say that even despite our best efforts, okay, so I do the same thing as Dr. Shah does. In those patients where I kind of say, wow, how I wish I could fix your tremor with medicines, except that you're not tolerating any of the medicines. So I do the DAT scan. If it's abnormal, beautiful. Then I do the skin test. Yep. Abnormal. So the chances of you responding to DBS will be higher. But is that a slam dunk,
Not
thing?
always.
Not always. because there are still atypical Parkinsonian syndromes like MSA or multiple system atrophy where the DAT scan will be abnormal, right?
And the sin is
And
positive
the
too.
skin biopsy is positive, right? But here's the kicker. Some patients with MSA may have some levodopa responsiveness in the
They
beginning.
do.
And that's where, again, we go back to this 4 or 5 years, right? Is the levodopa responsiveness enduring for many years? And then down the road, 4 or 5 years after, will they develop dyskinesias and motor fluctuations, which are hallmarks of levodopa responsive Parkinson's? Remember, what responds to DBS is levodopa responsive Parkinson's disease, not the atypical Parkinsonian syndromes. Yeah. Okay. What about medicine reductions? What is your style?
So I read your papers, though I've never been able to get him to zero meds. I don't know how you did it, but usually I get him to about, so post DBS, I can take the levodopa down about 60 to 70%. And I'm okay with that. I've had a few patients where I've been able to take them off levodopa completely. But they start having some withdrawals. They just don't feel good. The levodopa gives them a little bit of a mood benefit, and a lot of those patients just don't seem happy. I feel they're better if they have a little bit of levodopa running through their system.
Again, this is the management of Parkinson's among specialists like ourselves is an art. There's no wrong way to do this, right? There's many ways to skin the cat. So Dr. Shah just shared that he kind of is comfortable with doing 50 to 60%, whereas I'm more comfortable with doing a little less than that, and I try to aim for zero. But both approaches are perfectly fine.
Correct.
What is the bottom line? We treat the motor fluctuations and dyskinesias, and that we make the patients on, if we could, 24/7, and then we minimize the side effects and maximize the benefits, right? That's the bottom line. In other words, there must be improvement of their quality of life. But if you were to withdraw or reduce medicines, how quickly do you reduce medicines though?
So what I tell my Parkinson DBS patients is I tell them that after they get the surgery, I give them a couple weeks to rest, let the brain swelling from the implant and everything go down, and then I bring them into the office. I typically bring them in once a week, and what I'll do is I'll systematically increase the stimulator settings, and I'll systematically gradually lower meds. It typically takes on average about a 4 to 6 week regimen, which is 4 to 6 sessions, one session a week, until I can get to them about 60 to 70% reduction.
Yeah. So the faster you withdraw the medicines, the higher the chances they may get into withdrawal symptoms. There's such a thing called dopamine withdrawal syndrome.
Correct.
Or what we call DOWS. So the problem with this is that if you withdraw the dopamine agonist or dopaminergic agent like levodopa too fast, they miss it because remember it has a mood elevating effect. It has a good feel good effect on our Parkinson's patients. They're quote unquote a little bit addicted to it. Right. And so even if their tremors are good, they have no more off time, their dyskinesias are good, they're walking better, they got rid of their walker. Some of these patients, if we withdraw the dopamine agonist or levodopa too fast, they don't feel good. They feel crappy. They feel depressed. Some even feel just uneasy, unhappy, moody, irritable, sometimes even confused. And so what we do with these patients, we bring them, bring back the medicines at the previous dose, then we go a little slower. So as long as you titrate this down slowly, I think you can get away with the so-called dopamine withdrawal syndrome. And I think, at least in my hands, the ones that are most prone to this are those that are taking whopping doses of medicines. Taking whopping doses, I mean, that's a big jump between, let's say, 1,000 milligrams of levodopa to zero. That's a big jump, right? Versus somebody who started with 400 milligrams of levodopa per day, and then you're aiming for zero. That's less of a jump down, right? And then the other thing that predicts dopamine withdrawal syndrome are patients that are taking dopamine agonists. They love their dopamine agonists. It has a mood elevating effect. It helps their sleep. In fact, dopamine agonists are being used for depression outside of Parkinson's disease. It has an antidepressant, a depressive effect. And so some of these patients that are on whopping doses of dopamine agonists do better if you keep the dopamine agonist there,
Right.
in my experience.
At least a partial dose of it.
At least a partial dose of it. Agree. Okay, what about age-wise?
Do you have an age limit?
I used to when I started the DBS program at Mayo in 2001, and we didn't know what we were doing back then because DBS was very new, and so there were no clear guidelines as to what was the oldest. But we would just let everybody, that comes to our doors and signs that the consent form go through DBS, and we found out very quickly that the elderly patients don't do very well, and as well as the demented patients.
They don't. Now my oldest was 87.
And that's a tremor patient, right?
But correct. This is an essential tremor patient. He actually still remains on therapy, but he was a good 87. He still had his own business. He was running it. There was no signs of memory impairment in him. He was physically active. He just had really bad tremors that he couldn't function with them. But typically I get a little hesitant for my Parkinson's patients as they approach the high 70s.
Okay, so high 70s. So for the oldest one, and this patient might be in the audience, we have a patient that was about 84 years old. There was one that almost signed the consent form at 88 recently, but he backed out last minute. And I said, thank goodness he did. But because he was a very good 88-year-old, I was hoping that the neuropsychologist was going to say demented, right? In which case I get off the hook in case he gets dementia after DBS. But thank goodness, as of last follow-up, he was 88, although he was bothered by his symptoms. He's a very good 88, very healthy. Medical wise, I'd say he's 70, except that his records say he's 88. So it's just a number. But again, at the same time, I think the surgeon will get nervous about anyone in their 80s. Yeah. But in essential tremor, I've heard some of my colleagues have done 88. I have an 88, I think, in my practice, 88-year-old. So 87, 88, I think you're still okay. A good 88, right?
Yeah, he was a good 80. He was a good 87 at that time. Yeah.
Right.
So how about this? This is controversial. Would you implant someone with memory impairment?
Oh, wait, this is really controversial now. As to whether, first of all, how do you screen patients for cognitive impairment before DBS?
I usually send them to the neuropsych, and if the neuropsych shows cognitive impairment, at least moderate cognitive impairment, there's a discussion. Now, so this is always a risk benefit thing, right?
Sure.
So let's say you have a patient that is just floating on the line right above dementia.
Okay,
so they're not quite demented yet, but they're pretty close.
They're almost demented.
Almost demented.
Got it.
And if you DBS them, you're going to push them into dementia.
Right.
Because the brain takes a hit during the surgery.
From the anesthesia,
from
right?
the anesthesia, from the actual physical trauma of the surgery with the implant coming in.
And is this hit reversible though?
Depends on who it is.
Or depends on how good the surgery was.
Depends on how good the surgery was. Depends on how young the patient is. Depends on other medical issues.
Or how much anesthesia exposure there was.
anesthesia.
Awake versus asleep and so on and so forth. Okay, go.
So if you push them into dementia, and let's say if they were living on their own with their spouse and they were managing their household, they were having some problems, but they were still managing their household. Now you created a problem. Now they're demented. They need to be put in a home. It's a huge change of life for them. However, there are some patients where even though they are really poor, they have a very strong family network around them where their children or spouse is already involved and they're already been taken care of at home. So then it's like, sometimes I'll have a family meeting and I'll be like, are you okay with them being more demented? And the children are like, well, we do most of the stuff for them anyway, so why not? At least then they won't shake as much anymore. So it's gone both ways, but typically I usually stay away from taking that risk.
So in other words, it's so-called, pre-dementia or what we call advanced MCI, right? Advanced
MCI,
mild cognitive impairment. So this halfway house called MCI also has different stages. Some say early MCI, then moderate stage MCI, then advanced MCI. So just for the record, for early or moderate, there's no argument there, right? There's no debate about you're gonna push for DBS.
Yeah, they're still good candidates. Early, moderate.
And in fact, if we were to do neuropsychs on newly diagnosed Parkinson's within the first couple of years, a good percentage already have MCI without them even realizing that there is MCI. So MCI is very common even in early Parkinson's. We're talking about the advanced MCI. Okay, so my thoughts are, if they're taking whopping doses of medicines to start with, right? Because they have severe motor fluctuations, they have the severe dyskinesias, they're in polypharmacy, they're wearing off. And then the question is,
okay, so if we don't do DBS, let's project what your future will be, right?
Right.
Okay, this is your future in 1 year and 2 years. You're gonna take even higher doses of medicines because it's a one-way street when it comes to medicines in Parkinson's, right? There's no subtraction in Parkinson's, right? It's all addition. There's no such thing. Oh, why don't we just go back to the dose 2 years ago before I got this side effect? No, no, sorry, it doesn't work that way. It's a one-way street because the dopamine deficiency is progressive in Parkinson's. So you can there's no subtraction. Unless you were overdosed to start with, right? Then there's a little bit of a subtraction there. But so having said that, so we kind of say, okay, if we don't do DBS, you're going to need more medicines, which means more cognitive impairment, more hallucinations, more delusions, more dyskinesias. And then on top of that, you'll probably, the motor fluctuations, meaning the effect of the medicines will still become shorter and shorter. And therefore, you'll have more off time. And if you're off, you'll be weaker, more dependent, more unstable, more prone to falling, more freezing. And sometimes you have non-motor symptoms when you're off. You'll be cognitively worse. You'll be depressed. You'll be irritable when you're off, so-called non-motor symptom. You have more restless legs, right? You'll have more sleep disturbance, and so on and so forth. So we have this intimate, in-depth discussion. So is that a rosy picture versus, okay, let's take a risk here. Let's do DBS. I know you're advanced MCI. I know we're probably going to push you across the finish line towards dementia within a month after this, or probably right after surgery. But there is a chance that you might go back to where you were after a few months. It will take longer, but there's a chance you might go back. But the gain is the DBS will fix your tremor, the DBS will fix your motor fluctuations, the DBS will fix your dyskinesias. We will reduce the doses of medicines. Dr. Shah will aim to reduce your medicines by 50 to 60%. Beautiful, right? That means less medicine-related side effects. So I guess question is, would you want the motor symptoms to be fixed now and in the future with accelerating the onset of dementia versus I'll take my chances. At some point, I will become demented. I don't know, maybe a year from now, maybe 2 years from now. But now I'm stuck because I'm not a DBS candidate anymore. And therefore, I'll be stuck with the medicines that Dr. Shah and Dr. Evidente, would be giving me. So I'm going to take a poll, okay? A raise of hands. So raise your hands if you prefer to take your chances with DBS, fix all the Parkinson symptoms, but there is a small chance that you may accelerate the dementia and that it will stay there. Who prefers that option? But fix the Parkinson's forever, right? In other words, doses of medicines will be reduced and blah, blah, blah. Okay. Versus, I'm going to take my chances. I don't want this dementia to progress, but I will take my chances. I will need more medicines in the future and therefore more complications from the medicines in the future.
It's about 50-50.
It's like 50-50. There you go. And that's why you have a family meeting, right?
That's right.
There you go.
Now, I will say one thing. What is your opinion on younger Parkinson patient who is working? I don't DBS them. And the reason for that is even if they're healthy and young, for some reason after DBS, they can't really function that well in work. They can't multitask that well anymore. They have a harder time keeping up with schedules and meetings and things. There is a slight cognitive decrease after DBS, and that is pronounced, or that becomes more noticeable in let's say like a white collar patient. Let's say someone who's a lawyer, accountant, financial advisor, things like that. I typically do not DBS those patients.
So what age are you talking about when you say young?
So let's say they're 58.
Got it.
Parkinson's for
Less
5,
than
6
60.
years,
Got it.
but still working though.
Okay, so again, that's one way to skin the cat. The other way to skin the cat is, I say if they have motor fluctuations and they have dyskinesias, they've earned a ticket to DBS. The nice thing about when we talk about medication reduction, at least in our experience so far, since I'd say for the past 20 years, I think the ones that do the best with dramatic, almost zero, if not zero, reduction in medicines are number one, the younger patients. Number two, those without cognitive issues. Number three, those with less advanced disease. And number four, those taking less doses of medicines or less, overall levodopa equivalents. So to me, those are the predictive factors for, yep, I don't care what your age is. I think you're going to do well, regardless of the age. So I think age is just a number, at least in my opinion. I'm more concerned about the elderly, extremely elderly. I'm less concerned about the younger ones. And in fact, there was a study where they compared early DBS. So we're talking about the first 4 years right now, right there, well, in the slide. So first 4 years versus using their best medical therapy. And what they found out in this study, that those that had early DBS seem to fare better in terms of their motor symptoms and overall quality of life in comparison to best medical therapy. Yeah, and so I think early DBS at whatever age, as long as they're still good DBS candidates, would still be fine. What about focused ultrasound though? When do you use focused ultrasound?
To be honest with you, I'm not a big fan of it. It's a good alternative option. We have it available in Phoenix now. I think we've had it for about 2 years now at Barrow. Focused ultrasound is for those who don't know, it's a non-invasive option where basically they put you in an ultrasound machine and they use a high intensity ultrasound.
MRI, right? And an MRI.
And a function MRI, yeah.
Right.
And they use the ultrasound ray to essentially burn a region in the brain to treat the symptoms of tremors and Parkinson's and things. In my opinion, if you are healthy enough to get DBS, just get DBS because I think the results with DBS are better.
Yeah. But of course, there are patients that are deathly afraid of DBS, and I respect that completely. No matter how much I convince them, they say, "Oh, this really is not for me," and I don't think. And then I kind of I ask them this $64,000 question. Say, okay, but I know you're against DBS now, but in your lifetime, I say, do you think will you ever embrace DBS at some point? Will you get enough courage to say yes? If the answer is no, then I forget about DBS altogether because there's no hope. This patient is immovable. It's a choice which I perfectly respect, and therefore, I mean, why not do focused ultrasound?
Yeah, in those patients who are either deathly afraid of DBS or who are not good surgical anesthesia and those candidates that say they have a lot of comorbidities, the focused ultrasound is a good alternative.
And then does it work for all the Parkinson's features equally, or is one Parkinson's symptom better treated with focused ultrasound?
To be honest with you, I haven't actually focused ultrasound any of my Parkinson's patients.
Yeah.
It's taken them to DBS.
I've had a few that had focused ultrasound first.
What was your experience with it?
Okay, so tremor is the number one, which you wrote here. Tremor is the number one feature that improves. The only downside is it comes back in a few patients after as early as 2 years. Remember, it is a lesioning procedure. Lesioning means we burn a part of the brain. And this is going back to the olden days before DBS.
The telemotomy.
Yeah, back in the day, when you had tremor predominant Parkinson's, and that was your number one issue, okay, they would drill a burr hole. Well, let's say one side, if you have left-hand tremor, or if you're a right-hand tremor, they drill a hole on the opposite side of the head. So they drill a hole called a burr hole, and then they insert a probe, and then you can either freeze the tip of the probe or burn it or heat it up. Either or will achieve the same result. You will burn a part of the brain at the tip, which in this case is the VAM nucleus of the thalamus, right? Which controls tremors. And then the downside to that is it comes back after a few years. And number two, and then if it comes back, what do? Burn some more, right? Let's burn some more, right? No, you can't do that, right? There's only a finite amount of brain cells. I mean, who wants to keep burning their brain cells? We're already losing brain cells every day. As we're talking, all of us are losing a few hundred brain cells every second, right? So why even accelerate the process? So number one, it's best done unilaterally. Number two, it may come back. And then for bilateral procedures, they're talking about speech abnormalities, right? And difficulty swallowing, cognitive issues, and balance issues. So it really is best done for patients with unilateral tremor, unilateral, one-sided tremor. And that tremor is their number one issue. But the problem is, how many patients with Parkinson's only have tremor and nothing else?
Very few.
Exactly. And so what has happened to these patients of mine that came to me for DBS and had already focused ultrasound and the tremor came back. And not only that, now they have more features of Parkinson's, the so-called tremor predominant Parkinson's. Some of them don't remain tremor predominant forever. They will develop slowness of movements. They will develop rigidity. They will develop postural instability or balance issues. So the other features of Parkinson's come out down the road. Many patients with so-called tremor predominant in the beginning become just full-blown, the whole shebang kind of Parkinson's, garden variety Parkinson's patient with a bad tremor. In which case, probably doing this in both sides of the brain because they have symptoms in both sides, although it can be worse in one side, is probably not a good idea. Okay, another controversial issue here.
Another controversial issue, cannabis for Parkinson's. So marijuana was made legal, what? Was it at the 2020 election?
I think it was it 2020 or 2016? It's 2020, right?
I think it's 2020.
I think it's 2020, right?
So
I think in Arizona.
Yeah, correct. I'm in Arizona. So we know from a medical standpoint, and what is medically proven is that marijuana is helpful for anxiety and pain. So marijuana will treat anxiety and pain. It doesn't treat tremors. It doesn't treat shuffling. But a lot of patients' tremors are oftentimes derived or worsened if they're really anxious. And so I have a lot of patients say that, they take a gummy or they use the smoke, the vape, and they feel better. They don't have as many tremors. They're more relaxed. And yes, that is true. The marijuana will relax them. They'll lower their anxiety. And by default, they'll feel that they have less tremors and things. So from that perspective, it does work. If patients want constant relief through the day, unfortunately, the gummies only last for a couple hours. They would actually have to use a smoke vapor and smoke it through the day for constant relief. So I have some patients that do it. I'm not opposed to it as long as they are aware that it's really treating the anxiety and pain.
Got it. And you get a feel as to which one patient's style is more effective. Is it the smoke? Is it the vape?
The smoke is more.
gummies?
The smoke and vapor are much more effective than the
Got it.
gummies.
Are we talking of THC with CBD or just pure CBD?
No, the THC. I think if they want the full benefits, they do actually have to use the THC products.
Unfortunately, it is the THC that causes, psychotropic,
Correct.
side effects, psychedelic side effects.
Correct.
And what are these psychedelic side effects? Confusion, hallucinations. It's the one that makes you feel good. Okay, so the THC is the feel good. I am high. I'm gonna forget all about my problems. That's the THC. The one that has the therapeutic value though is the CBD, right? At least in some patients. But are there good studies though of CBD or THC for Parkinson's? Are you aware of any?
I don't believe so. Are you?
No, I'm not aware. I mean, I've seen. I mean, if you go to YouTube, I guess.
Oh, yeah.
I guess there's a lot of testimonials there. They'll show you. Oh, look at me. Oh, Trevor like this.
You have
Then I
you have the videos, right?
get a little high. Then look at me. Voila, no more tremor. And then I saw another one with dyskinesias like this, and he's a young fellow with Parkinson's. He vaped a few marijuana, and said he's still a rock
seen
like
that.
this. Wow.
Yeah.
So is that science though? Just because I saw this in YouTube, is that good science?
I think part of those patients' dyskinesias and things were probably derived by their anxiety, and I think once they treated the anxiety with the vape, they just felt more relaxed and they were less dyskinetic.
However, I don't want to completely discount it because here's the because. Is there a relationship between the cannabinoid receptors, because this is cannabis, right? If it works in your brain, and that's where Parkinson's is, right? The brain, right? And what part of the brain is involved in Parkinson's? It's the basal ganglia. It is the motor centers that control your movements, the so-called basal ganglia. So big question is, are there cannabinoid receptors in the basal ganglia, which is involved in Parkinson's and a lot of movement disorders? And the answer is yes. There are cannabinoid receptors. There are two kinds of cannabinoid receptors. There's CB1 and CB2. Now, CB1 is the one that's very rich in the basal ganglia. Unfortunately, it's the THC that stimulates the CB1. It's the one that gives you a high and makes you crazy and goofy and feel good. The CBD, which is cannabidiol, which is the other component of marijuana or of cannabis, doesn't stimulate the CB1 receptors. What it does is it induces or releases your endogenous cannabinoid substances. You do produce some substances in your inherent cannabinoid substances in your brain. So what it does, it enhances the production of your own cannabinoids in your brain, and so that's how it works. So yes, there's probably receptors. Yes, it's probably going to influence the basal ganglia, but the absence of studies makes us feel like, well, are we really going to do this? There's no hard, evidence for it yet. And yet now that it's already, I mean, you can get it for leisure, right? Who the heck will invest $1 billion for the FDA to get something approved? But is there an FDA approved version of cannabis in the US? The answer is yes. There's a brand name called Epidiolex. Epidiolex. It is so expensive, and it's only FDA approved for a special kind of seizure disorder. Okay, so it's usually used by pediatricians, pediatric epileptologists use this Epidiolex. Some of my wealthy patients have tried using it. It's pure CBD. It's pure CBD, but it's industrial grade, guaranteed to be safe kind of CBD, as against one you get in the streets, right? You're not even sure, what contaminants there are with that. Okay. Oh, this is a good one. Thiamine.
This is a good one.
Yeah.
So
How many of you have heard about thiamine recently in Parkinson's? Raise your hand. There we go. We have a few.
there was there's been a few studies. One that I like the most was this one, where they actually controlled the enrollment like participants. And so all of these patients in the study had normal serum thiamine levels. They had no signs of cognitive impairment or a neuropathy, and they were given an intramuscular injection of 100 to 200 milligrams of thiamine twice weekly. And after 15 days, most of them showed an average of 30% improvement in their motor scores. And I believe the science behind it, now it's a little controversial, but the thought is that in Parkinson's disease, in the substantia nigra, where Parkinson's disease occurs, there is actually down regulation of the thiamine receptors and the production of it in there. So if you check someone's blood level, their blood level thiamine is normal, but the actual thiamine that's absorbed in the cells in the Parkinson areas is deficient. And when you supplement them with thiamine, you are improving those functions. Now, the downside to this, though, is high levels of thiamine can actually cause a neuropathy. Patients can get numbness, tingling, burning on the feet. Because I still see some general neurology in my practice, and I have
I see neuropathy a lot. I say, oh no, it's a neuropathy case.
You do the blood test, and then the thiamine levels are really high, and then so you tell them, you got to cut back on some of the multivitamins and the things. So yeah, there is a downside to doing this, but that's my understanding of how this is working.
So do you have actual patients that say, like a testimonial from a patient? Oh yeah, Dr. Shah, I started thiamine and I'm a lot better.
I do not. You?
Okay, I don't either. But is there anyone in the audience that want to share their experience? Anyone has tried thiamine in the audience? Now, what is thiamine? It's B1.
Vitamin B1, yeah.
Okay, so what sets of patients or individuals are prone to thiamine deficiency? Not Parkinson's. So Parkinson's patients, except if you're malnourished. So that's one group of patients, malnourished patients, or patients with GI absorption issues, or patients who've had a gastric bypass, right? Or the even more common group of patients that are prone to developing thiamine deficiency are alcoholics. Okay, so if I see a patient, a Parkinson's patient, right, and I say, wow, you got Parkinson's, but you also got bad neuropathy. I kind of look at them with, look at them eye to eye, kind of, are you drinking? And then they kind of say, well, just a little bit, un poquito. They say, and then you get the real score, and then you get the real score. They're drinking like a bottle of wine every day, right? because it helps their tremors or dyskinesias. So having said that, so in the Parkinson's population, it's the alcoholics that are more prone to thiamine deficiency. So whenever I see Parkinson's with bad neuropathy, but can Parkinson's though lead to neuropathy?
So actually, I think it can, because on the SYN1 biopsy test, a lot of the patients have neuropathy,
Small fiber neuropathy.
small fiber neuropathy, and the thought is the alpha-synuclein toxin disrupts peripheral nerves.
There was a study that showed that patients taking whopping doses of levodopa, the higher the dose, the higher the chances you will be B6 deficient and B12 deficient. And in fact, one of the precautions with a form of levodopa called Duopa is I do a B6 and B12 test first at baseline, and then down the road, I kind of monitor the B6 and B12 because this is a more powerful form, direct to the jejunum form of levodopa. But if you do that, you avert the chances of them developing neuropathy from Parkinson's. But anyway, I guess thiamine, there's a lot of press about it recently. I don't think there's much value, right, on its own.
I don't think so. And if patients want to initiate one, the studies have been done with intramuscular injection, so they have to have access to that, and then you have to have
And it's twice a week.
Twice a week, yeah. That's what we're doing it. And
Wow.
so you have to have
What's wrong with the oral thiamine? 100 milligrams thiamine, which you get from Costco or.
I'm not sure. I don't know if there's much
I think it has to do with the absorption, though.
Probably.
I think the absorption is much better for the intramuscular and therefore gets to the so-called crosses the blood-brain barrier a little better.
And if they do this, they have to make sure there's someone who's going to be monitoring the thiamine levels. Because if it becomes toxic, they're going to have a neuropathy.
And mind you, I read some of these studies. You know, their thiamine levels to start with were normal.
Correct. The beginning thiamine levels were normal. Yeah.
Yeah, it's not like they were thiamine deficient. So the question is, is that a real effect, or is that a placebo effect? Which of all the disorders, neurological disorders, the ones that with one of the greatest placebo effect is Parkinson's. What that means is, I'll give you placebo, right? In a drug study, you're receiving not the real drug, and then you will get better, right? Because Dr. Shah says you're gonna get better with this study drug, right? Or myself. But the opposite can happen. You can get worse, and it's called placebo effect. Placebo. Okay, you can get worse and even get side effects from placebo. And it's like, wow, how did the patient get nauseous, dizzy, drops in blood pressure, depressed, and so on and so forth? And then when the study ended, you were on placebo, so this was all in your mind, right? This was not me, not the study drug. This was the placebo. That's exactly why we have placebo studies. Yeah. Okay, what else do you have?
How about vitamin B12?
Okay, so what's the basis for that?
So I couldn't find any human studies. The biggest studies were in mice models, which were infused with MPTP, which is a neurotoxin. Wasn't it a form of street meth in the 70s?
I think so. Yeah. I don't know.
I wasn't around back then, so.
Yes, I was.
So in those mice, now the MPTP is a type of poison that when you inject into mice, it actually causes them to have Parkinson's. And what they found was when those mice were fed in this solution that had high concentrations of B12, they tested their movement in glass cases, and they saw that there was some advantage. And then when they stained the cells in the substantia nigra, there was less oxidative damage. The problem, though, is 250 milligrams per kg per day. That is a lot of vitamin.
That's a lot of vitamin.
Like, you would have to just be drinking a gallon of vitamin B12 to compensate for this. I mean,
and just putting things in perspective, how many milligrams would that be for 60 kilograms? It's about what? 12,000, 13,000, almost 14. That's whopping.
Yeah.
Yeah. The normal vitamin B12 you get over the counter is like 1,000 micrograms.
Yeah. Right? So that's like 200 tablets.
I know, right? That's whopping.
So I think if the vitamin B12 levels are normal, I don't think there's much utility in exogenous usage of vitamin B12 to raise that.
Agree. Now, there was a Mayo Clinic study that was published, I'd say maybe about 10 years ago, if I remember this right. But they found out that, for number one, that B12 deficiency is quite common in Parkinson's patients. In fact, if I remember the numbers, it's like almost 20%. of Parkinson's patients in their cohort, just random Parkinson's patients they tested had B12 deficiency. And then those that were B12 deficient had more cognitive issues, more neuropathy, and more falls. Okay, so whenever I see those three, right? Why are you getting demented so fast? Are you just you're only 2 years into Parkinson's? Why have you developed a neuropathy? And then I kind of say, oh, you're taking whopping dose of levodopa now, or why are you falling? What's this? Why are you feeling weak? I don't know what this means. So I do test for B12 in those cases, and if we replace the B12 and if they're B12 deficient, they do get better. I have patients that get intramuscular injections of B12 every month after a diagnosis with profound B12 deficiency. They do get better. So this is something that we cannot afford to miss.